Hello. Today, I'd like to talk about important considerations in neck ultrasound examinations. This patient was suspected of having multiple lymph node metastasis in the left lateral neck. A fine needle aspiration performed at an outside hospital diagnosed metastatic thyroid cancer. At that time, the outside hospital ultrasound showed multiple thyroid nodules, but none were considered suspicious for thyroid cancer. At our institution, an ultrasound examination was performed, and a 5 mm thyroid cancer was identified at the very uppermost portion of the left thyroid lobe. The next patient had a thyroid nodule in the right thyroid lobe that had been considered highly likely benign for the past 9 years. Over time, the cystic component decreased, the solid component increased, and the nodule gradually enlarged. Before visiting our hospital, the patient underwent 3 evaluations. 2 fine needle aspiration biopsies showed benign results, but the final core needle biopsy suggested a follicular neoplasm. Because a follicular neoplasm was suspected on biopsy, the patient visited our hospital for surgery. On ultrasound performed at our institution, the nodule had decreased in size, and its morphology had changed to a suspicious appearance. As explained in a previous video, this corresponds to a mummified nodule. This patient visited our hospital for surgery after an outside hospital biopsy suggested a follicular neoplasm. As part of the preoperative workup, staging ultrasound and several blood tests were performed. Before the ultrasound, I reviewed the patient's medical records and noted an elevated parathyroid hormone level. Taking this into account, I performed the ultrasound and suspected a parathyroid lesion at the upper portion of the right thyroid lobe. A parathyroid scan was subsequently performed for localization, but the lesion was not clearly visualized. However, on choline PET, uptake was observed at the same location suspected on ultrasound, allowing successful localization of the parathyroid lesion. The patient underwent surgery, and the diagnosis was confirmed as follows. The next patient had an elevated parathyroid hormone level detected at an outside hospital and underwent a neck ultrasound. Only thyroid nodules were identified, and no parathyroid lesion was visualized. These are the ultrasound images obtained at the outside hospital. At our institution, ultrasound revealed a parathyroid lesion inferior to the left thyroid lobe, and the same location was confirmed on scintigraphy. I will now show you the ultrasound video of this patient. When performing neck ultrasound, lesions are most commonly missed at the extreme upper and lower poles of the thyroid gland. To be confident that the entire thyroid has been adequately examined, scanning should continue superiorly and inferiorly until the triangular area, where thyroid echogenicity is no longer visible, is clearly identified. In neck ultrasound, it is essential not only to examine up to the triangular ends of the thyroid, but also to make it a habit to include a wider field from the submental area superiorly to the lower neck down to the sternum. Doing so helps prevent missing morphological abnormalities of the thyroid as well as other important surrounding structures. Thank you.